Jonathan, this is Dr. Jones and our internal medicine service team.
Hi. Hi, Jonathan.
I'm going to be presenting your case to them. Is that all right if I do that in the presence of your girlfriend and coworker here?
Yes, that's fine.
Thanks, Jonathan. So this is the first UMC visit for Jonathan, who is a 24-year-old African-American with a history of sickle cell disease who presented to the emergency department with a 2-day history of bilateral knee pain. He's ectomorphic and is in moderate distress. The pain began Tuesday at approximately 4 a.m. While he was working a night shift at Walmart. He had difficulty sleeping because of the pain that night, and the pain gradually continued to increase due to a severity of 8 out of 10 today. The pain was exacerbated with walking and standing, and was not significantly relieved with Percocet, which he received from another physician that we aren't sure who it was. Jonathan has never experienced knee pain to this extent before, but he did say that he's had a few episodes in the distant past of knee pain. He reports some chills and mild shortness of breath, but he denied fever, nausea, vomiting, cough, chest pain, abdominal pain, or recent trauma to the knees. He has no other known medical illness and isn't on any chronic medication for sickle cell disease either. In the ED, he was given an IV bolus and received 2 doses of morphine at 6 milligrams and 8 milligram doses. For past medical history, he was diagnosed with sickle cell disease at age 6 and has had 6 to 8 previous hospitalizations for that. He has a history of lower extremity ulcers as well, but he has never had a pneumococcal vaccine, which is interesting. His social history includes he lives with his mother and 4 siblings. He works at Walmart as a stalker, but denies any IV drug use or tobacco use. He does consume alcohol occasionally, and last time was this last weekend. He has 2 siblings that also have sickle cell disease. In the review of systems, it was negative except for lower extremity ulcers and intermittent left hand pain. In his vitals, he had a temperature of 36.3 degrees Celsius, heart rate of 96, respiratory rate of 16, blood pressure of 108/70, and his O2 saturation was 89% on room air. For HENT, he's normocephalic, atraumatic, Perle, and extraocular movements are intact. With lungs, they're clear to auscultation and percussion with no wheezes, rales, or bronchi. CV, his S1, S2 were normal. He is tachycardic with a soft flow murmur heard at the base. There was no S4, but he does have decreased pedal pulses. For abdominal exam, bowel sounds are normal and the spleen tip was not palpable. GU, he didn't have any urethral discharge either. For skin, he had a silver scaly rash on the flexor surface of the right elbow, and there are non-healing bilateral ulcers of 1 centimeter diameter on both medial malleoli. For musculoskeletal, he has mild swelling of the right knee and small effusion. There's no erythema, and it's not tender to palpation, but there was pain on full extension. His left knee didn't have any significant swelling or tenderness, and he did have full range of motion bilaterally with his knees. In lab work, we have a CBC, BMP, and liver function test pending. And so, in conclusion, or in summary, Jonathan, he's a 24-year-old African-American man with a history of sickle cell disease and hypoxia. He presented to the emergency department with bilateral knee pain and minor right knee effusion. On the differential diagnosis, we have vaso-occlusive disease, periarticular infarct, septic arthritis, and gout. Vaso-occlusive disease is most likely due to the afebrile presentation of the patient. And the pending CBC results will likely rule out septic arthritis due to a gram-negative Neisseria, staph, or salmonella. Potential plans of treatment include knee pain. For knee pain, we would consider NSAID treatment with morphine for breakthrough pain. For sickle cell disease, we should monitor closely for acute chest syndrome, splenic sequestration, and aplastic crisis, and consult a hemonc for a sickle cell referral after he is released from the hospital. And then we should also obtain a chest x-ray to rule out new infiltrates and consider oxygen therapy if he becomes symptomatic in his lungs again.
All right, any questions?
Well, I'd also recommend adding 2 liters of oxygen via nasal cannula.
I think that'd be a great idea. And great job, Bryce. You really were very thorough. Thank you for letting us present in front of you. That was really great. Thank you.